Critical Thinking and Coding Tips for Chapter 20. Okay, our first critical thinking question. What are the treatments for prostate cancer, prostate hypertrophy, and prostatitis? And the answer, typically a patient will undergo some sort of prostatectomy, whether it's excision or destruction. There are many different approaches and levels of prostatectomies, including transurethral with ultrasound, which is a guided laser induced prostatectomy, or a TULIP as it may be called, transurethral prostatectomy, suprapubic prostatectomy, transvesical prostatectomy, retropubic prostatectomy, cryoablation, and perineal or transperineal prostatectomy, radical prostatectomy, transurethral destruction of prostate tissue by microwave therapy, and transurethral destruction of prostate tissue by other therapy, including thermotherapy and transurethral needle ablation. Now, each one of these ICD-9-CM procedure codes is different based on the technique and approach. It's important to review the operative report in order to code accurately. After the original procedure is done, depending on the extent of the disease, follow-up may be required involving chemotherapy, radiation, further resection, or lymph node biopsy and/or removal. Now, our next critical thinking question, what treatments are there for urinary incontinence? And the answer, collagen injections are the most non-invasive way to treat urinary incontinence. If that fails, or if the incontinence continues to progress, the other treatments are surgical. Now, these include plication of the urethrovesical junction, suprapubic sling, retropubic urethral suspension, paraurethral suspension, levator muscle operation for urethrovesical suspension, and suburethral sling included in other repair of urinary stress incontinence. Okay, and our final critical thinking question for this chapter. What dilemmas are coders faced with when coding urinary tract infections? And the answer, there are many determinations to be made when a urinary tract infection is documented. First, is there an organism defined as causing the infection? It's important to review any urine cultures and note if there's any organisms greater than 100,000, because this typically indicates a urinary tract infection. Now, look for documentation of the patient receiving antibiotics as treatment, and be aware of whether there is a contaminant suspected during the culture. Now, this should be documented on the culture itself. If this is the case, a UTI should not be coded unless a follow-up culture is done and the physician correlates these findings in the medical record. The next step might be to determine what part of the urinary tract has the infection. This may require a query by the physician to determine whether the patient has pyelonephritis, which is an upper urinary infection, cystitis or urethritis, which are both lower urinary tract infections. In most cases, however, the code 599.0 will be assigned for urinary tract infection, site not specified. Now, here are our coding tips for this chapter. The differences between chronic kidney disease and acute renal failure, and why the two codes can both be coded on a record. And the guidelines are, acute renal failure has a sudden onset and renal function is severely impaired. It's also reversible with treatment. Chronic kidney disease is a gradual loss of kidney function with progressively more severe renal insufficiency until end-stage renal disease takes place. A patient can be in chronic kidney disease and then have a sudden acute onset of severe renal impairment, which would be acute renal failure. Now, in this case, both the chronic kidney disease and acute renal failure would be coded. In most instances, the acute renal failure is the reason for admission because that is what has brought the patient to the hospital. Now, the chronic kidney disease is something the patient has had and can be coded as a secondary diagnosis. Okay, continuing on with our coding tips. The use of the genitourinary specific V codes. V56.0, which is admission for hemodialysis, and V56.8, which is admission for peritoneal dialysis. These are sequenced as principal when this is the reason for the admission to the hospital. Always code the kidney disease as a secondary diagnosis to further describe the reason for the dialysis. Now, V45.11, which is renal dialysis status, can be used as a secondary diagnosis to show that the patient is currently receiving dialysis, but perhaps not on this admission to the hospital. Now, the relationship between kidney disease and diabetes. The physician must document diabetic nephropathy in order for the relationship between kidney disease and diabetes to be made. Now, sometimes kidney disease results from both hypertension and diabetes. In this case, use the hypertension and or kidney disease combination code 403.XX and the diabetic nephropathy code 250.4X. Also, code any secondary diagnosis to further describe the stage of chronic kidney disease from 585.X and or the kind of diabetic kidney disease, which could include glomerulosclerosis, nephritis, or nephrosis, etc. And our last coding tip, the relationship between chronic kidney disease and hypertension. Now, ICD-9-CM presumes a relationship between these two conditions, so the combination code of 403.XX should always be used if both conditions are documented, unless the physician states that the chronic kidney disease is due to another cause. An additional code of 585.X must also be coded to explain the stage of kidney disease the patient has at the time of the hospital stay. This relationship is not assumed with acute renal failure or secondary hypertension.